Okay, so the CDC has produced a document basically in 2019 looking at antibiotic resistant threats. This is the most recent threats divided up into whether or not they're urgent, serious, or concerning threats. And so obviously the urgent threats are the ones that are of interest to us, but serious threats are also something that we are concerned with also. So, let's see. So I'm going to discuss ESBL producing Enterobacterales, carbapenem resistant Enterobacterales, and then multi-drug resistant or difficult to treat Pseudomonas aeruginosa in types of organisms. So here's what we're going to talk about then. So multi-drug resistant organisms are
But I don't
blood cultures, if it's from some other site, then the lab may have to do some additional testing to identify that particular enzyme. If the isolate is resistant to ceftriaxone, that can be used as a proxy for ESBL production. And so that's always something that you can look at. You can say, okay, E. coli, is it resistant to ceftriaxone? Then it's probably an ESBL producing isolate. So remember, in complicated urinary tract infections, it's recommended to give Bactrim or fluoroquinolones unless you have patients that maybe have side effect profiles or incompatibilities with those types of antibiotics. And so then obviously you can use a carbapenem. And so a carbapenem is something that we try to minimize our use if we can. And it's been recommended that if you start a carbapenem and you find out that you have an ESBL, it may be appropriate to switch patients off of a carbapenem to Bactrim or a fluoroquinolone to complete therapy. At our institution, we don't use a lot of aminoglycosides, but those are also something that can be used and could be used. We don't like to use a lot of phosphomycin or doxycycline or nitrofurantoin because those drugs don't get into the renal parenchymal tissue very well. And so in complicated urinary tract infections, it's to be avoided. So if you have an ESBL outside the urinary tract, then certainly a carbapenem is appropriate. If a patient has hypoalbuminemia, and that's usually defined as an albumin less than 2.5, then we try to use meropenem or imipenem just because of the high protein binding associated with ertapenem. And so there's about a 5-fold risk of mortality using ertapenem for patients with hypoalbuminemia. And so that's something that we try to get people off of ertapenem if they have low albumins. So the next case of beta-lactamases are the AMP-C producing beta-lactamases. Here you can see that these are a group of enzymes that are produced at basal levels. So they're produced at low levels empirically during therapy. And then these are mostly in Enterobacterales and then glucose non-fermenting gram-negative organisms. The highlighted increased AMP-C production, the inducible chromosomal gene expression can happen, and it's difficult to know what's going to happen in those types of patients. So there are some organisms that produce the AMP-C very high, and the Enterobacterales or the Enterobacter cloacae, the Klebsiella aerogenus, and the Citrobacter farendii are the 3 main AMP-C producers. Providentia, Serratia, and Morganella can also produce AMP-C, but they usually don't get induced. They usually produce AMP-C at a high enough level. The other 2 mechanisms of AMP-C production, the stable chromosomal gene deregulation or derepression and the constitutive expressed AMP-C genes on plasmids, usually have AMP-C produced at a very high level. So you don't usually see that induction. You don't see somebody whose organism is sensitive at the beginning of therapy and then develops resistance towards the middle of therapy. So these are common beta-lactams for inducing the AMP-C gene, ampicillin, amoxicillin, first-generation cephalosporins. cefotetan, cefoxitin, and then imipenem. So then the next antibiotic resistant threat that I want to talk about would be the carbapenem resistant enterobacterales, which is the fourth one down from the urgent threats there. And so here we have to talk about the different beta-lactamase productions that are out there. So the Ambler classification actually has 4 different groups. 3 of them are serine beta-lactamases, and the class B are metallo-beta-lactamases. These all can produce either penicillinases, cephalosporinases, or carbapenemases. So the class A serine beta-lactamase, a good example would be your KPC, which is the carbapenemase. We have some effective inhibitors, but we don't have any effective inhibitors for the metallo-beta-lactamases, the NDMs, and things like that. So that's a hole in our armamentarium. So the carbapenem resistant enterobacterales, Klebsiella pneumoniae is the most dominant carbapenemase that's produced. It was first found in 2001 in a patient in North Carolina. We actually, the CDC has data to show that KPCs in the last 5 years have gone from 74% to 51% in overall incidence. But the oxacillinases have gone from 1% to 8% over the same time frame. And New Delhi metallo-beta-lactamases have gone from 2% to 20%. So those are probably very important things that we have to keep in mind. The oxacillinases are more common over in Europe than they are here in the United States. And the New Delhi metallo-beta-lactamases are primarily a result of medical, surgical, where people have gone to get cosmetic surgery in India because it's cheaper. And so we have some sporadic cases in the US, but that's increasing over a period of time. So what should we use when we have a KPC isolate outside of the urinary tract? Ackley et al. At the University of North Carolina, as well as investigators in Orlando in their healthcare system, evaluated the utility of using ceftazidime avibactam, meropenem vaporbactam, or imipenem relobactam. And the in vitro activity for all 3 of these was very good, over 95%. In this particular study, or in this observational trial, it looked at clinical cure and 30-day mortality, and the ceftazidime avibactam group had a 61% clinical cure and a 19% mortality. The meropenem vaporbactam had an 85% clinical cure and only 12% mortality. Of interest, though, is the number of recurrent carbapenem-resistant infections that now were resistant. There was 20% in the ceftazidime avibactam and none in the meropenem vaporbactam group. They additionally only had 5 patients that received the imipenem relobactam. So even though they reported that, they didn't analyze it because of the low numbers. Weaknesses of this particular study is that it was an observational study, and there was probably some selection bias associated with the which group patients got into as far as what they got for antimicrobials. So newer options that are FDA approved include cifidrocol and aztreonam avibactam that I want to talk about a little bit. So cifidrocol is a siderophore cephalosporin that basically here's the antibiotic part, and then here's the catechol moiety that basically binds to ferric ions and then gets transported into the bacterial cell through the iron channel, and then disassociates from the catechol and inhibits cell wall synthesis. So in this particular study, this is the APEX NP study, where basically it was a randomized double-blind phase 3 trial looking at patients that had gram-negative hospital-acquired pneumonia or ventilator-associated pneumonia. And patients got cifidrocol or meropenem. And the primary endpoint was all-cause mortality at day 14. 86% of the patients had an organism that met the criteria for inclusion. 37% of those were Klebsiella pneumoniae. 16% were either Pseudomonas or Acinetobacter, and there was a small percentage of E. coli also in this particular study. If you look on the right-hand side, you can see the results. There was about an equal number of patients, 12% in both groups that met the primary endpoint at day 14. So another study that looked at different antibiotics for treating metallo-beta-lactamases is the study from Falcone et al. In Pisa, Italy. In this particular study, they have metallo-beta-lactamases as endemic in this part of Italy. And so they looked at their antibiotics that were used for carbapenem-resistant Enterobacterales that were New Delhi metallo-beta-lactamases or any type of metallo-beta-lactamases. And they divided up their patients into patients who received cifidrocol or cifidrocol-containing regimens, patients who had colistin-based regimens, patients who had other active agents, and then ceftazidime, avibactam plus aztreonam was the majority of the patients. And here you can see the mortality rate for each of the different categories of patients. It's interesting because the cifidrocol group, there was only 4 patients that received cifidrocol monotherapy. Everybody else in that particular category received combination therapy. And you can see the Cox regression analysis that there was a significant, or the ceftazidime, avibactam, aztreonam group was protective for mortality compared to colistin-based therapy in this particular study. So next is aztreonam avibactam. This is a review article from Mike Ryback's group in Detroit. They basically looked at all of the metallo-beta-lactamases and the susceptibilities, in vitro susceptibilities, looking at the MIC 90s, the MIC range, and then the percent susceptible. And you can see those isolates that got aztreonam avibactam had 100% susceptibility, and the MIC 90 was fairly decent. The other agents, with the exception of maybe tigecycline, were all pretty poor in terms of percent susceptible. So the revisit trial is a trial looking at the use of aztreonam avibactam compared to meropenem plus colistin. And for complicated interabdominal infections, patients were enrolled
with Astrinam avibactam plus metronidazole. And 298 patients were enrolled compared to 104. So it was a 2-to-1 enrollment. They also enrolled a fair number of HAP and VAP patients, 74 versus 36 for the meropenem colistin arm. They had quite a number of Enterobacterales. However, the number of Enterobacterales in this study that were resistant was only about 4%. So treatment duration wasn't different. Cure rates for interabdominal infections or hospital acquired infections were not different, and the 28-day mortality was not significantly different. So in this particular trial, even though they didn't get a lot of resistant isolates, it showed that Astrinam avibactam with the addition of metronidazole could be useful in complicated interabdominal infections and then ventilator-associated pneumonia. So here we have another case of a patient that was admitted to our hospital with she had a ventral hernia repair. She got exploratory lap. She was sent to the long-term care facility, developed fever, and so she came back. Her urine culture was drawn and it showed these particular susceptibilities. And so this is somewhat common at our facility. And so this also, she also had positive blood cultures for the same isolate. So multi-drug resistant Pseudomonas is not susceptible to any antibiotic in more than 2 classes. They also have a new category called difficult to treat Pseudomonas, and they have quite a number of different resistance mechanisms, cephalosporinases, efflux pumps, and PDE mutations, and then OX10 beta-lactamase producing. And so in these particular agents, or in these particular cases, then it's probably good to go ahead and get susceptibilities for some of these more defined, more difficult to treat isolates. And so, you know, ceftolozane tazobactam has pretty good activity. Ceftazidime, maybe Bactam, maybe a little bit lower. And then cefiderocol is also something that you can get susceptibilities for these Pseudomonas aeruginosus. In our hospital, we probably use some ceftolozane tazobactam while we're waiting for our cefiderocol susceptibilities, because it appears that there's just as much resistance that develops to ceftolozane tazobactam as there is for ceftazidime avibactam. And so that's can be problematic for patients. So if you have a multi-drug resistant Pseudomonas that's not susceptible to carbapenems, then you want to use high dose extended infusion or some of the newer beta-lactam agents like cefiderocol or ceftolozane tazobactam. And so with that, then I'll just go ahead and give you my summary here. Ceftazidime avibactam is probably pretty useful for KPC producing organisms. Ceftolozane tazobactam can be useful for difficult to treat Pseudomonas. Cefiderocol is useful for all 3 of these types of multi-drug resistant, and then Astrinam avibactam is probably going to be useful for Stenotrophomonas and Acinetobacters that are New Delhi metallo-beta-lactamase producers. And so with that, I'll try and take any questions if anybody has any.